Okay, this is Unit 4, and this is the second half. And we've talked about blood and spinal fluid and body fluids, and all of those are considered sterile sites. So anything that grows, you have to identify it because it's probably the pathogen. There are some cases with contaminated blood cultures, and sometimes there may be some contamination with the catheter tips, but for the most part, they're sterile body fluids. Well, now we're going to start on respiratory specimens, and in the respiratory tract, there is a whole bunch of normal flora organisms. There's normal flora in our mouth and on our teeth and on our in our nose and down our throat, um, in our ear, everywhere. Or not deep in our ear, but in the outer ear. There's just organisms galore. So one of the things that we have to do when we have respiratory specimens is decide if what is growing is normal flora or is it a pathogen, because there are some that could be both. For example, strep pneumo can be a pathogen, and strep pneumo can also be normal flora in a patient. So what do we look at? We look at the patient's age. Usually infants and the elderly are more at risk. They have a more um, um, not so competent immune system as patients in the middle. Their immune system, consider what the organism is, what kind of organism it is, and what's wrong with the patient. Have they had any type of surgery? Have they been on chemo? Those kinds of things. Their symptoms, a previous positive culture. Have they been on in the hospital? Have they been on antibiotics? Do they have some type of chronic illness? If so, we look for gram-negative rods. Just the patient situation, like what is going on with the patient. And two examples are foreign body obstruction or aspiration. But just the patient, what is wrong with the patient in general? Why are they there? What could have caused this pathogen, if there is one, to be there? Okay, so another thing we look at is the gram stain results. So basically, if you see an organism with gobs and gobs of white cells, you think there's a pathogen there. But if you see organisms and there's a lot of different types of organisms, then especially if you see a bunch of epis, then you would suspect that that is a contaminant. So we always do a gram stain on sputum. We may not always do one on ear infections or the throat, but we do one on all sputum. And that's what we look for. How many organisms are there? How many different types do we have? Gram-positive cocci, gram-negative rods, gram-positive rods, all of those. And are there white cells or are there epis? So that's the first thing we look at to tell if the patient has a pathogen or if it's normal flora. Okay, the culture results. How many types of organisms are growing? Is it a pathogen? Could it be normal flora that has turned into a pathogen? For example, strep pneumo can be normal flora in the throat, but if it gets down into the lungs, it's a pathogen because the lungs are supposed to be sterile. So we have to keep that in mind. With the upper and lower respiratory cultures, there's usually normal flora in them. The upper respiratory tract has the nose, mouth, throat, epiglottis, and the larynx. The middle ear and the sinuses are connected to that. Sometimes the normal flora from the nose, mouth, throat, epiglottis can get into the sinuses and cause an infection, I'm sure you know. And the lower respiratory tract includes the trachea, bronchioles, and the lungs. And this is usually sterile. This is a really good example of what a sputum or a throat would look like. And you can see, if you look at it real closely, you can tell that there's more than one kind of organism there. There's something here that looks like an alpha strep. There's a small little white colony, and then over here, these bigger grayer ones, and right up here, looks like another type of organism. So, and there may be more because it's a picture and you can't see it really well. You need to pay attention to the organisms that are normal flora in each of these sites. So on page 8 in your notes, I want you to look at the normal flora of the mouth, the nose, and the nasopharynx and the oropharynx. Look at the mouth. Staph epi, alpha strep, lactobacillus. Look, there's Staph aureus, enterococcus, and candida. That's a yeast. The nose and the nasopharynx, Staph aureus, strep, Haemophilus parainfluenza, strep pneumo, Moraxella catarrhalis, Neisseria meningitidis. All of those things can cause, not all of them, but Moraxella, Neisseria, Staph aureus, those can cause infection, but they're also normal flora. In the oropharynx, Staph aureus, Moraxella, group A, that's what causes strep throat. Neisseria meningitidis, Haemophilus influenza. The reason I'm saying those particular ones is because they can be pathogens. They're normal flora, but they can get into the sinuses, or like strep pneumo can get into the sputum and into the lungs, and cause an infection. Okay, pharyngitis is the most common upper respiratory tract infection. If you've had this before, you know there's pharynx exudates, fever, painful adenopathy, no cough, and difficulty swallowing. It hurts really bad to swallow. And I've known of a couple people to have strep and they didn't even run a fever. It's usually in school-age children. It's usually not even the majority of the infections. Usually when you go to a doctor and you've got these symptoms, they'll do a rapid strep, and if it's negative, they won't give you any antibiotics, because if it's not strep, then it's most likely a virus. The viruses, there's a whole bunch of different kinds. 50% are the rhinovirus, which is what the common cold is, or it could be early influenza. It could be the early flu before you start to feel, more terrible. Uncommon pathogens, gonorrhea and Corynebacterium diphtheriae. You need to make sure that you know the common pathogens for each type of specimen. We have a patient who has pharyngitis. We do a rapid antigen test. This is just a throat swab, and we do a little rapid test on it. And if it's negative, we do a throat culture. And the throat culture is to look for other bacteria that could be causing the sore throat. Or maybe there's a small amount of group A and the test is not coming up positive, which doesn't happen very often, but it can. The pharynx and the tonsils are swabbed. You have to be careful not to touch the insides of the mouth or the teeth or the tongue. It should be put into a transport swab, and we don't do anaerobic cultures on throats, never ever. Anaerobes do not like oxygen, so if you have a specimen from the throat, there's going to be oxygen there, so anaerobes shouldn't grow. The gram stain is not done because of all of the normal flora. It's not going to be helpful. With the rapid antigen testing, it's usually latex agglutination or an enzyme immunoassay, and that's what this is. When you look for a line, this is what this is, and this is the most common type that hospitals and doctors' offices use. So if that's negative, we need to use a swab to do a backup culture, and we usually do a blood for adults, but a blood and a chocolate for children under 6. And this has to be a separate swab. So whoever is collecting the specimen has to originally get 2 swabs when they collect it. So if they collect 2, they put them right together, right side by side, and hold them in one hand and collect the specimen at one time and submit those 2 swabs. So on the blood agar, you're primarily looking for beta hemolytic colonies because that's what group A is going to look like. So you hold it up to the light and you screen for beta hemolysis. If you see beta hemolysis, then you proceed to work it up as group A strep. So you would do a gram stain. You would do a catalase to see if that's what they have. The chocolate is used for Haemophilus influenza, and we're going to get to what that infection is. Sometimes there are other pathogens. I've seen patients that had almost a pure colony of Pseudomonas in their throat. It's kind of rare, but other organisms can be the pathogen. And we usually don't worry about those unless they're in great numbers, like if that organism is 75% or more of all the colonies. Okay, this is the Haemophilus influenza, and this infection is called epiglottitis. And this is an infection of the epiglottis, and you know that's the flap back in your throat. The symptoms: sore throat, painful swallowing, fever. It's usually in children less than 6, and it's life-threatening. They can actually suffocate. And this is called from Haemophilus influenza type B. Since the Hib vaccine has been given, it doesn't cause many infections anymore. Epiglottis cultures are dangerous to collect. They can make it worse, so blood cultures are what's preferred. On the gram stain, Haemophilus influenza will be tiny gram-negative rods or gram-negative coccobacilli, and a blood and a chocolate are set up for that. Okay, otitis media is the infection of the middle ear. Patients have fever, irritability, ear pain, hearing change, drainage, usually in children less than 10, and typically after a viral infection. And if you've had any little kids, you know that they get a cold and then end up with an ear infection. What happens most of the time is normal flora from the upper respiratory tract gets into the middle ear through the eustachian tube. The tubes in children's ears are much shorter than adults, and it's easier for them to for bacteria to travel there. Most commonly, you need to know the most common ones. Most common is strep pneumo and Haemophilus influenza. The others can be group A, Staph aureus, Moraxella, anaerobes, gram-negative rods, mycoplasma, and chlamydia. Newborns, group B. Viruses, and again that comes from the vaginal tract. Viruses, respiratory syncytial virus or RSV, rhinoviruses, influenza, adenovirus, and rarely fungus and mycobacteria. Okay, specimen collection. If there's fluid, then a tympanocentesis can be done, and this is done by puncturing the tympanic membrane and getting some fluid, and this would be a severe case. And if you've had children, you know they don't even try to do cultures of the ear. They usually just prescribe antibiotics. When things like this are done, the infection is severe and they're not able to treat it with common antibiotics that are used, and they need a culture to figure out what kind of organism it is. A gram stain can be done. The culture, an aerobic culture, the blood McConkie chocolate would be set up. An anaerobic culture, the anaerobic plates are BBE and CDC. I don't know if you remember, but BBE is for Bacteroides, and CDC is it's the anaerobic blood agar plate. If the eardrum has ruptured, then we should suspect an anaerobe, so we would need to culture those. Okay, an outer ear infection is otitis externa, and these organisms are Staph aureus, group A, Pseudomonas, which is the one that causes swimmer's ear, usually in the summer. Other gram-negative rods like E. coli and some in that group, Moraxella, Haemophilus influenza, and Strep pneumoniae. An ear swab can be done unless there's drainage or exudates. Those can be collected and cultured. And again, cultures of these are not done very often. Okay, sinusitis is infection of the paranasal sinuses. So I don't know if you've all had sinus infection, but it can be a miserable thing. There's nasal discharge, pain in the face, headache, fever, and other things as well. Your ears can clog up, and it can just be miserable. The community-acquired ones are strep pneumo, Haemophilus influenza. Hospital-acquired is group A, Moraxella, Staph aureus, and gram-negative rods like E. coli. And less common are anaerobes, viridans, and fungus. The specimens are usually only cultured when a patient has a bad infection and it's not responding to antibiotics. A sinus aspirate can be done, and this is the best specimen. A neonate can have a swab done of the opening of the sinuses, and nasal or nasopharyngeal swabs are not usually helpful because of all the normal flora that is there. Gram staining culture can be done to pick up these organisms. Okay, pertussis. This is the whooping cough. These patients have paroxysms of coughing worsening at night. It's highly contagious. They have breathing difficulty, and the main pathogen is Bordetella pertussis that causes this. There are two other ones in that family, Parapertussis and Bronchoseptica, but they're not very common, and also they don't cause as a severe infection as pertussis does. The specimen collection is usually a nasopharyngeal swab, and once it's collected, it needs to be placed in transport media right away because it's a fragile organism and it will die. So we put it in transport media that has Reagan Low in it. A calcium alginate swab needs to be used because the other types may kill the organism. It will not grow on blood, McConkie, or chocolate. You've got to use a specialized agar called Bordet Ginkgo, and also usually what is done is a direct fluorescent stain. So we put this specimen on the slide and we have some special fluorescent stain that's used, and the organism will fluoresce, and you look at it under a fluorescent scope. And there's also newer PCR tests that can be done. Okay, the lower respiratory tract. The three most common types of infections are bronchitis, pneumonia, that's inflammation of the lung tissue, and it can be a primary infection or a secondary from something else that's going on. Anemia is pus in the thorax that's associated with pneumonia that can show up on an x-ray. The specimen collection is very, very important in collections of the lower respiratory tract. The most common specimen is a sputum that's coughed up from the lungs. And when you cough it up, it has to go through the throat and the mouth. So there is a high probability that normal flora will get into the specimen on its way out. So when the patient is able to produce a sputum on their own, it's done from a first morning specimen when they first rise. That's supposed to be the best specimen for sputums because the organisms have time to pull down there and you can cough up more. It's done in a sterile cup. If there's dentures in the patient's mouth, those are supposed to be removed. Gargle to rinse the mouth out, but they're not supposed to gargle with mouthwash. This is just water. Saliva should not be submitted for a sputum. This is just spit. It needs to be a deep cough coming from the lungs. Sometimes the patients are unable to cough anything up, and if this happens, then respiratory therapy can come in and do an induced sputum collection. They aerosol the patient with saline, and coughing is induced, and they're able to cough some up. However, these specimens do look a lot like saliva. They don't usually look like a true sputum, but it's not saliva. It does come from the lungs. A tracheostomy and an endotracheal aspirate is when a bronchoscope is passed down through the nose or the mouth into the bronchus to look around and to get specimens for us. Bronchial washing, brushings, and the aspirates and open lung aspirates, all of these can be collected usually from the OR, and they're sent to us to be cultured. And we usually do gram stains on all types of these specimens. Okay. Bronchitis is usually caused from mainly viruses. Pneumonia, RSV, strep pneumo, Mycoplasma pneumoniae, Haemophilus influenza, gram-negative rods, Staph aureus, Legionella, anaerobes, mycobacteria, and fungi. Chronic pneumonia is mycobacteria and fungi. Anemia is Staph aureus, strep pneumo, group A, gram-negative rods, and anaerobes. Others that we have to keep in mind are influenza, the avian flu, and SARS. And the last two, the avian flu is the bird flu, and SARS was the severe acute respiratory syndrome a few years back, in which patients who traveled to another country would became sick, and they weren't exactly sure what caused it. Okay, other facts. Strep pneumo is the most common cause of community-acquired. Staph aureus is seen in community-acquired and hospital-acquired. Haemophilus influenza is seen in pneumonia in children and adults. Enterobacteriaceae, all of those have the potential to cause pneumonia, but Klebsiella and Serratia are the most common. Klebsiella usually has a jelly-like sputum. The non-fermenting gram-negative rods, Pseudomonas is the most commonly seen. Usually Pseudomonas is seen in patients who are on a ventilator, mainly because they like water. They like the moisture that is created. Burkholderia, this is also Pseudomonas cepacia. It's an organism that often infects patients who have cystic fibrosis. And Pseudomonas can also produce a jelly-like sputum, and these have been known to have a green color tinge to them also. Moraxella from pre-existing lung disease like emphysema or lung cancer. Anaerobes from aspirations. Legionella, most often seen in immunocompromised. A BCYE agar needs to be used. Mycobacteria is TB, so an AFB culture would need to be done to pick those up. Mycoplasma pneumoniae is seen in older children and adolescents, young adults less than 30. So I would say anywhere from 12 to 30, usually in the adolescent range. This causes an infection, and these organisms are really fragile and they need extra things to grow. So a lot of places will do a fast EIA kit to check for those. Chlamydia from the mother's vaginal tract during delivery can cause newborn pneumonia. And Chlamydia pneumoniae in young adults. Bacillus anthracis, which is the gram-positive rod that causes anthrax, can cause the pneumonia, which is not very common. Anthracis is usually seen more with skin infections. Okay, so on all sputums, a gram stain is always done first. We mainly do the gram stain for acceptability, and what we're trying to find out is if the sputum is a good sputum from the lungs, or if it's saliva, if it's from the mouth and it's contaminated with normal flora. So what we do is look at the specimen on low power. We look at it on 10, the 10x objective, and we count how many white cells and epithelial cells we see in a field, and we get a good average. You look at least 10 or more fields and get a good average. So basically, if you see a lot of epis, there's going to be contamination. If you see a lot of PMNs, then that means infection, because the white cells are going to come in and try to fight the infection off. So look at these results. Specimens that have greater than 25 PMNs, that's the white cells, less than 10 epis. So it's mainly white cells, not hardly any epis. This is a good specimen. It's free of contamination. It's probably got the pathogen in it if it's there. Specimens that have hardly no white cells and more than 25 epis are contaminated. They have to be rejected. We have to call and report that we're rejecting it, and we need another specimen. One of the hardest things to do is a sputum because of the strep pneumo. Strep pneumo can be normal flora in this kind of specimen, and it can be in here and be the pathogen. Bacteria are quantitated on oil immersion. After you get the results for the white cells and the epis, you do the bacteria and you quantitate them on oil immersion, and you say how many you see of what kind. Also for sputum, AFBs can be done to check for TB, fungus cultures. For a regular sputum, we do a gram stain. Blood McConkey chocolate is set up on a routine basis. Okay, these are examples of two different sputums on the 10X objective, and these are PMNs. And a lot of times when students are first trying to look at these, they can't tell that these are PMNs, and they have to go to 100 to tell. But if you look really good, maybe at that one, you can tell it's got at least 3 lobes. This is a neutrophil, and we usually call it a PMN in a sputum, and all of these are neutrophils. So this has got a bunch of white cells in it. Now look over here, you can tell all of these are epis, and we wouldn't know unless we went to oil immersion, but some of this is probably bacteria, because when there's a lot of epis, there's a lot of bacteria too. So this one would need to be rejected. It looks horrible. And this one is a good specimen with white cells, and it probably has the pathogen there if there is one. Okay, eye cultures. We don't do very many eye cultures unless it's something severe. Even if it's pink eye, a lot of times antibiotic drops are given, and only in the cases where the patients don't respond to antibiotics do cultures get done. The normal flora in the eye are coag-negative staph, diphthroids, Staph aureus, Propionibacterium, Haemophilus influenza, which can also cause pink eye, Strep pneumoniae, which can also cause pink eye, Staph aureus can also cause pink eye, gram-negative rods can also cause pink eye, Bacillus, and Neisseria. Okay, itching and tearing and discharge of the eye are all symptoms. If you've ever had anything wrong with your eye, you know how uncomfortable that can be. Risk factors: is the patient on steroids or antibiotic therapy? Because this can make them susceptible to getting a pathogen. Their immune status, their age, and the integrity of their eye. Is their eye, okay? Or do they have cataracts, or have they had an accident to the eye? Types of eye infections. Conjunctivitis. These are infections of the mucous membranes covering the eyeball and eyelids, and it's commonly known as the pink eye. And you'll see how many different pathogens there are. Adenovirus, chlamydia, herpes simplex virus, Staph aureus is the most frequent, Haemophilus influenza biotype aegyptius. This is Haemophilus influenza is just a different biotype, a different strain. Strep pneumo, Enterobacteriaceae, especially in children, Neisseria gonorrhea from the birth canal, and chlamydia also. Neisseria meningitidis, Pseudomonas, fungal infections like Candida and Sporothrix, and parasites like Loa loa. Keratitis is infection of the cornea. Staph aureus is the most frequent. Pseudomonas, Mycobacteria, Acanthamoeba, Naegleria, Fusarium, which is a fungus that we didn't have to know, and Aspergillus. Endophthalmitis is infection of the interior of the eyeball, and usually these are coag-negative staphs like Staph epi or Staph saprophyticus, and Bacillus, which is a gram-positive rod. Ophthalmia neonatum is conjunctivitis and keratitis in the newborn. When a baby is born, there is a law that requires drops to be put in the baby's eyes to prevent Neisseria gonorrhea and chlamydia from causing them an eye infection, because they could cause blindness. Silver nitrate used to be put in the baby's eyes, but now erythromycin is used. Okay, routine culture, usually from a swab from the part that's infected. Scrapings can be done. This is usually done by a ophthalmologist. The cornea can be anesthetized and it can be collected with a Chimera platinum spatula where they just actually just scrape it. Eye chamber fluid, we usually suspect anaerobes. Chlamydia has to have a calcium alginate swab because other kinds of swabs can kill it. And viral infections, Dacron swabs, and parasites, corneal scraping can be done. Bacterial conjunctivitis, there'll be PMNs, white cells, and bacteria, usually neutrophils. Viral conjunctivitis, there'll be lymphs and monos, but also white cell, those are the only white cells. There won't be any bacteria unless there's some normal flora. We may see a little bit of bacteria there. AFB stain can be done for chlamydia. Fluorescent stains can be done, and what you look for in a fluorescent stain for chlamydia are intracytoplasmic inclusions. And basically, these are just little small circles inside of the white cells that where it's infected the white cells or the tissue cells in the eye. Fungal infections, a calcifluor white and a KOH can be done. Okay, routine eye culture usually has blood, chocolate, McConkey, thio, and or anaerobic media. For chlamydia infections, McCoy or Hep2 cells for culture, or PCR or EIA procedures. Viral infections have to be put in viral transport media, and other things like if Mycobacterium is suspected, the Lewiston-Jensen slant can be used or plate. Fungi, that's the Saborodextrose agar, that can be used. Viral media, if gonorrhea is inspected, like in a baby, Thayer Martin or Martin Lewis has to be used. Pseudomonas agar, special Brucella agar, and if you remember, one of the things with the Canthamoeba is it will eat the E. coli on a plate. So you can put a drop of the specimen on a plate that's got E. coli growing on it, and you'll see where it's eating at it if the organism is there.